Welcome, everybody. It's a real pleasure for me to introduce our speaker today, Dr. Sebastian Kurz. Dr. Kurz did his early medical training in Marburg, Germany, and subsequently at the Julius Maximilians University in Würzburg, Germany. He subsequently got his PhD also in Würzburg, Germany, entitled Transcriptome Analysis of Neisseria meningitidis with DNA Microarrays. He went on to do his residency training in Munich, Germany, then came to the United States where he did a requisite second internship and residency program at the Case Western Reserve School of Medicine in Cleveland. He did his pulmonary fellowship, pulmonary critical care fellowship, also at Case Western, and then he joined the faculty at Tufts University School of Medicine in Boston in 2014. Subsequently was promoted to Associate Professor of Medicine at the Icahn School of Medicine at Mount Sinai in New York, where he was also the clinical director of the bronchiectasis program there. For family reasons, he returned to Germany between 2022 and 2024 and was an attending physician in both pulmonary and oncology at the University of Tübingen in Germany. But we were extremely fortunate to have recruited him and also, I dare say, his wife, who's in neuro-oncology here at Yale. But we were very, very fortunate to recruit Sebastian to Yale this past spring. And he's already not only a valued and well-liked, but highly revered member of our pulmonary and critical care family and faculty. He's the director of our outpatient COPD clinic in the overarching, multifaceted Yale Center for Asthma and Airways Diseases and the Winchester Center for Lung Disease, and is also very involved in our bronchiectasis program and our comprehensive pulmonary program. Dr. Kurz has received several professional honors and awards, including most recently the American College of Chest Physicians Distinguished Chest Educator Award in 2024, has previously also been Teacher of the Year and received award for that at his home institutions. He has participated in several clinical trials related to non-tuberculous mycobacteria and bronchiectasis in the past. He is known both locally, regionally, nationally, and internationally for his expertise in inflammatory airways diseases and bronchiectasis, including infectious lung disease, such as tuberculosis and non-tuberculous mycobacteria. He's been a speaker nationally and internationally on these topics. He serves as a reviewer for many journals and is the associate editor for the journal Respiratory Medicine. He has many publications in such distinguished journals as BMC Pulmonary Medicine, Clinical Infectious Diseases, Chest Physician, Infectious Disease Clinics of North America, Annals of ATS, and many others. He has also contributed to both consensus statements and practice guidelines regarding non-tuberculous mycobacteria and TB management. So we are really thrilled to have him as a key member of our Yale COPD program, as well as within our multifaceted overall YCAD team, and to have him to deliver today's grand rounds, which is entitled COPD More Colorful Than You Might Think, exploring the intersection between COPD and systemic disease. And I think this is a hugely important topic because the heterogeneity of COPD has increasingly been recognized in recent years, and the number of things that one has to think about as far as background illness as risk factors for and as impacting COPD has ballooned in scope. And so this will be an important lecture for all of us. So welcome, Sebastian. We're so glad to have you. Thanks.
Thank you so much, Carly. Thank you so much for this very kind introduction. I just wanted to add, I was just following along with my wife. So, I have no particular disclosures for this talk. And this is part of the color I had mentioned in my title. So these are three histology slides, which depict here a disease, small airways, and a lymph follicle next to it. So these are examples of follicular bronchiolitis, essentially, respiratory bronchiolitis. And we're going to come back to these histology slides in a minute. So what is COPD? Actually, this morning, I asked Google AI to give me an answer. And the answer I got is it's chronic obstructive pulmonary disease, a chronic lung disease that damages the airways and makes breathing difficult. A little bit more sophisticated is the answer that the GOLD Consortium has given us, updated 2023. COPD is a heterogeneous lung condition characterized by chronic respiratory symptoms due to abnormalities of the airways and or alveoli that cause persistent, often progressive airflow obstruction. We look at the global perspective, about 10% it's been estimated of the global population are afflicted by COPD. That's based on large cohort studies, the Platino and the BOLD study, which I'm sure some people know about. Less than 50% of smokers do develop COPD, and about 50% of worldwide COPD cases are not associated with smoking. So to learn more about what the underlying process could be, I think it's good to have a look at people who develop obstructive lung disease who actually have been never smokers. So there was a nice systematic review published a couple of years ago in the Lancet Respiratory Medicine, where they looked cumulatively at all these studies. I have highlighted some more well-known. The BOLD study I had mentioned, the Platino study, and then there's a large Canadian study, the CAN-GOLD study, where they look at several thousand patients. And all of them showed that the prevalence of never smokers among the cohorts were about 30%. When you look at potential exposures, air pollution comes up, occupational exposures. Think about coal mining, but also it's been associated with farming. Poorly controlled asthma, environmental tobacco smoking, secondhand smoking, infections, and early life exposures that eventually lead to impairment in lung function or lung development. When you look at the clinical spectrum of these non-smoking COPD patients, they tend to have less sputum production, less exertional dyspnea, milder degree of airflow obstruction, less severe emphysema, but more, take note, small airway disease, and they do have similar exacerbation rates. When you look at the global distribution, there is, it's called a gradient between heavily tobacco associated, which applies to high income countries, and low tobacco exposure, which applies to countries with low socioeconomic status. And here, household air pollution from indoor cooking and so forth becomes much more of a driving factor. Another thing that we have learned is that patients who have COPD do not follow all the same trajectory of their lung function. What has been shown is that people may, this is like what we would expect, right? You grow up, your lungs get bigger, and in early adulthood, you reach your peak of your lung function. And then there is, with age, a steady decline in your lung function. Depending on you and your environmental exposures, you may follow a slope that leads to a more rapid decline compared to somebody else. Alternatively, you may actually be an individual that has not reached this, what we would consider normal pulmonary function at early adulthood for events that happened in childhood early on. So you essentially start from a very low level. When you look at all comers, and that study was published now 10 years ago, looking at this COPD population, 50% had a high peak but a rapid decline that developed symptomatic COPD, and 50% had actually a low peak and then had a variable decline. So much, it's a sign of how heterogeneous that disease can present. So if you think about that is like the traditional simple view, you have a lung that's been set on fire essentially, leading to inflammation of the airways and eventually destruction of lung tissue. And by divine or diabolic reasons, some people do develop chronic bronchitis and some people do develop emphysema. This has gotten much more complex. We now know that there are many different exposures that can lead to COPD. We know that the inflammatory profile can be very different from neutrophilic predominant. Now, in the last couple of years, we look much more into eosinophilic predominant inflammation. And I'm going to show example of lymphocytic and adaptive immunity that plays a role in disease manifestation. And we do see chronic bronchitis, emphysema, and small airway disease with it. So this is a statement, a large review statement that was published 3 years ago, the Lancet Commission towards the Elimination of Chronic Obstructive Pulmonary Disease. And the purpose of that review was to shed a new light on all these complex mechanisms to see how we can do better to treat and mitigate the disease. So they have proposed several COPD etiologies. Big ones in the middle: environmental factors, smoking, still most common, adding vaping, marijuana, biomass burning, which I had mentioned, coal mining, livestock farming, and all these exposures. Infection, childhood pneumonia, HIV, TB. We're going to have a closer look at those entities. Long-standing asthma. Think about abnormal lung development, not reaching that peak or having a low peak of your lung function. And then there are genetic determinants, most classically the alpha-1 antitrypsin deficiency. So that's the approach I like to take for the next 30 minutes, coming back to these colorful histology slides. So slide number 1 is from a patient who really had tobacco-induced COPD with emphysema and concomitant follicular bronchiolitis. Slide in the middle is a patient who had rheumatoid arthritis with associated follicular bronchiolitis. And the patient number 3 had active tuberculosis leading to follicular bronchiolitis. So let's have a look at the middle one here, the one with rheumatoid arthritis. So that is a patient I saw during my time in Tübingen. It was a referral for a second opinion from our surgeon who had gotten this patient as a second opinion from his clinic. So a 50-year-old smoker, history of rheumatoid arthritis and COPD, and who had developed an empyema, presumably due to a pneumococcal pneumonia. In April 22, he had a decortication at another hospital. They started the VATS. It looked complicated, so it was converted to open. In 4 months later, he had to have a redo thoracotomy with decortication, and he ended up with a non-healing bronchopulmonary fistula. In December 22, a open thorax window was placed due to this persistent fistula. And 1 year later, he came to our center for a second opinion, question, can you close that window? So this is a CAT scan. There are some emphysematous changes on the lungs, and he did have a history of symptomatic COPD and rheumatoid, as I mentioned before this happened. Here you see the defect here in the chest wall, and you got the idea that there may be some opening to one of the airways here, which turned out to be the mediobasal segment on the right side. So what we did is we did a bronchoscopy, and we put a balloon catheter into that segment, and we injected some methylene blue, and then we took the bronchoscope out and put the camera into the chest cavity to see if there is still a communication. And as you can see here, there was we found the methylene blue in the chest cavity. So that fistula had not closed. So question, what are you going to do, right? So the surgeon cannot close a window. Should you increase enhanced immunosuppression to make that heal because it's a sign of active disease? Or should you decrease immunosuppression because there is impaired wound healing? And for sure, you know, the patient should quit smoking. So we had a discussion with that, and he said, well, doc, you know, I've been sitting at home for like over 1 year with a packed chest. I have nothing else to do. So it was a very difficult situation, but we said, well, for sure we cannot close that chest. So was it just a coincidence that this person developed both COPD and rheumatoid arthritis, or is there some sort of an interplay going on? I think our clinical impression is we see it fairly common. However, we also noted that both a disease of the elderly. So we're going to have a look at the clinical evidence. We're going to have a look at potential pathogenesis, and we also should think about other airway manifestations of rheumatoid arthritis. So last year, there are 2 studies published that looked into the incidence, the coincidence of COPD and RA. One was published in Chest. It was coming out of South Korea, where they looked at insurance data, and they looked at 46,000 patients with a diagnosis of RA and matched them with 230,000 patients as a control. And they followed them along between 2010 and 2017 and monitored until 2019. So what they found is that the incidence of COPD was about 5 per 1,000 patient years in patients with rheumatoid arthritis, compared to only half of the incidence, 2.23, in matched controls. So this is what they found, that they followed them along for a couple of years. Here, the blue line, you see people with the diagnosis of rheumatoid arthritis, if they get diagnosed with COPD, compare that with a control group. They further divided them into people who had a diagnosis with seropositive RA, meaning a positive rheumatoid factor and or CCP, and they found that relation was even stronger compared to seronegative ones. Same year, last year, another study was published that looked at the UK Biobank data. This is a very large-scale prospective ongoing study where they have more than 500,000 individuals between middle and older age. They collect sociodemographic data, lifestyle data, health status, biosamples, and match them with electronic record data where they can look at first occurrence of certain diseases, data and cause of death. So they looked at more than 400,000 individuals, and about 1.2% of them had RA, and 1.7% of them had COPD. So again, they followed them along. What they found is if you have RA at baseline, you're more likely to develop COPD. But they also find if you have COPD at baseline, you're more likely to develop RA. So there appears to be a bidirectional relationship between those two diseases. Why is this? So there are 2 hypotheses that are being discussed, and I'm going to just present both of them. You know, hypothesis A is, well, you know, you have an unfortunate interaction between smoking in your genes. It leads to inflammation in your airways, leads to formation of this bronchus-associated lymph tissue. And because of your inhaled injury, your proteins get citrulline, and you develop autoantibodies that eventually is going to cause rheumatoid arthritis in your joints. The second hypothesis is, well, you have an unfortunate interaction between smoking and your DNA. You do develop autoantibodies somewhere in your body that's going to attack both your joints and your airways. And there are arguments and data for both of these hypotheses, so I think the jury is still out. We shouldn't forget about other airway diseases we can see with rheumatoid arthritis. The classical one is constrictive bronchiolitis, which is a little different entity. It has a different clinical course, and when you look under the microscope, it's really a purely fibrotic fibrotic process at the terminal bronchioli, so different to what you would expect with COPD. Nevertheless, it looks like small airways are vulnerable in patients with rheumatoid arthritis. We also see large airway disease has been association with bronchiectasis. They sometimes see amyloid, secondary amyloid in the airways and other manifestations. All right, let's have a look at this case. A 37-year-old woman I had seen with shortness of breath. That was a couple of years ago at Sinai. She did not have a history of smoking, but she had obstruction on lung function testing. And here you can see the cuts in and expiration on the CAT scan. And you may see that, may appreciate that the left lower lobe is kind of darker. What do you want to know? What do you want to ask the patient? Childhood infections, exactly right. So she told me, yeah, my mom told me when I was 2 years old, I was in the hospital with a bad pneumonia. I was on an oxygen tent. So this is Swyer-James-McLeod syndrome, which is a late sequelae of childhood infection. We think it's primarily a destruction of the small airways, the bronchiolitis to start with, and then secondarily, you have essentially lack of ventilation, lack of perfusion, and that gives you that black lung. It can be a marker that you do have like a bronchiolitis picture in other parts of the lungs. So it's the fact that you did have obstructive PFTs may not be totally explained by this very isolated finding on this CAT scan. So let's have a closer look about at COPD and infection. So the big three are childhood infection, as I'd shown you in this case, HIV and TB. This is a chest X-ray of my son when he was 2 years old. He got a bad RSV pneumonia and he was hospitalized for 2 weeks. RSV, as you know, affects kids at a very early age. They have very small airways, so that airway inflammation does cause significant obstruction. It has been associated with future obstructive lung disease, mostly known as adolescent asthma. And this argument is still out there. If you are born as an asthma, like with an asthma phenotype, are you prone to develop reactive airway disease? And that is a manifestation. Now you've got an infection that causes obstruction at an early age. And as you grow, you're just going to have the phenotype of asthma, or is it actually the causative agent of causing obstructive airway disease? The data on COPD are not as clear. I will show you some, but overall, I think it's very reasonable to think about that recurrent childhood infections are associated with COPD at a later stage. We know it well now as a cause of COPD exacerbation in adults. Last week I was at St. Raphael's. I think I counted 2 patients who were in the ICU due to COPD exacerbation due to RSV. And we have vaccines now available. There's a monoclonal antibody, which is now recommended by the CDC for small kids right at the beginning of the RSV season. It's highly protective. And there are classical RSV vaccinations now being recommended for pregnant mothers to protect the kids, people 60 years and older with risk factors for respiratory disease, and all comers at the age of 75. So we should pay attention and recommend it to our patients as we see them in our clinic. This is a systematic review of how early childhood respiratory infections and pneumonia are being associated with impaired lung function later in life. I think one of the most convincing ones is a study up here from Allinson that was published 2017, more than 2,000 people. The exposure happened at age of 2 years or earlier. And spirometry happened later in life, about 43, and there was a significant lower absolute value for FEV1 compared to controls, an average of 71 cc's less. So looking back at the graph of how lung function develops and these different trajectories, this is where we talk about that early life events lead to an impairment essentially in lung growth, airway growth, that lead to a lower peak lung function, which makes you more prone to develop symptomatic diseases later on. So let's move on to our next case. A 51-year-old man I saw in Tübingen. He had a diagnosis of AIDS. He was on antiretroviral therapy, but he decided, I want to visit my family in Kenya. I don't have access to my therapy there. I'm just going to stop it. So he went to Kenya for, I think, 3 to 4 months. And when he came back, he had wasting, had fevers, and he had short of breath. And that was his CAT scan. So any concerns with that? What could that be? Pneumocystis, right? It would be the first one to think of. So of course he underwent a bronchoscopy. Pneumocystis was negative, surprisingly, but it was a lymphocytic predominant BAL, and his CD8 count was 90%. So a CD8 predominant lymphocytic BAL, and that would be consistent with diagnosis of LIP, lymphocytic interstitial pneumonia that has been seen. We do see a poorly controlled HIV patient, and it's usually a CD8 predominant picture. So let's look at COPD and HIV. We see higher rates of emphysema in people with HIV who smoke, faster lung function decline, and lower DLCO, which tends to correlate with CD4 counts. And we do see small airway disease. Interplay is complex. We think that HIV infected epithelial cells have an impact, or like cell layers and cell barriers tend to break down, tight junctions tend to loosen. We know that alveolar macrophages getting infected. Alveolar macrophages are the cells that live the longest in the lungs, so they may even serve as a reservoir for HIV, and they're known to spill out all sorts of pro-inflammatory cytokines. We have a dysfunctional CD4 cell response to pathogens. And we do have, as is seen in this gentleman, an expansion of CD8 positive cells. When you think about the histology of LIP, we know it's a different of cystic lung disease. Where do the cysts come from? It's thought to be a ball valve mechanism on the small airway level. So again, a sign that small airway are affected by. These associations tend to hold true even in people that are being treated with effective ART. So there are several studies out there that look at cohorts. I picked this one that was published 2015. The patients that were stable on antiretroviral therapy, the Lung HIV Consortium. Here they look at 900 people with HIV, a median age of 50. 68% were current smokers at the time. 37% had normal spirometry, 27% with obstruction. When you look at the odds ratio for more than 20 pack, you're smoking 1.68 for obstruction on PFTs. That's smaller than the odds ratio for having a history of pneumocystis pneumonia, brings you up to 1.97. How about kids? This is a study that was recently published from South Africa, Cape Town. We looked at 78 adolescents who had a perinatal HIV infection and compared them to 16 matched controls. They found out of the 78, 51 had mosaicism on expiratory imaging, which is shown here. This is a healthy control. That's the patient with HIV without obvious mosaicism. There's a change in the density map of that lung compared to a healthy control. And then here the third HIV positive with mosaicism on CAT scan. So again, thinking about what's your peak lung function at early adulthood and what's the trajectory as you go on with your life, I think these kids do have a very high risk of developing obstructive lung disease later on, irrespective if they're smoking. So when you look at the interplay between COPD and HIV, I think people with HIV should have PFT screens. Effective HIV treatment is important, though, as I had shown you, it does mitigate, but it doesn't completely take away the increased risk of developing COPD. That's why smoking cessation is highly important. Infection prevention, I saw the data on PCP. Similar data are out there for CMV infections and other respiratory infections. Think about respiratory vaccines these patients should get. As a side note, when we see this patient in the office, there is a potential interaction between some of the retroviral therapies and our inhaled corticosteroids. Ritonavir, for example, blocks one of the liver metabolizing enzymes. So it takes away the first pass elimination of inhaled corticosteroids so people can get this type of Cushing syndrome. I had one patient when I was a resident at the VA. He didn't take it in inhaled form, but he took it orally for HIV-associated colitis. And he developed full-blown Cushing syndrome because of that interaction. So it's real.
This patient that you showed the CT scan, that one, the LIP was in the central. You mentioned that one. LIP is another one that cystic.
Yes. So that was LIP. Yeah. So the question was if that was LIP. Indeed, it was LIP. So it was a lymphocytic predominant BAL and with negative microbiology. So we gave him the diagnosis of LIP. And we looked close at the CAT scan. There were several cysts also seen. Okay, coming to this case, a 35-year-old woman in Tibet, I also saw in New York. She had a history of delayed diagnosis of TB. What happened was she was pregnant in her third trimester. And she got, like people thought, right, you got a pneumonia, you cough, you got fever, take amoxicillin, didn't get better. Eventually she got hemoptysis and somebody got a chest x-ray and she was diagnosed with TB. A couple of years later, she presented with two things. Number one, progressive short of breath. And number two, again, new onset hemoptysis. So this is the CAT scan we got, and as you can appreciate here, especially on the right, this mosaicism in her lung parenchyma. Because of her hemoptysis, she was bronch. Actually, that was the cause of hemoptysis. She had a small cavity, which turned out to be MAC, not a recurrence of her TB. It was a MAC infection, and she got bronched. I'll show you the bronch here. So she had several airway lesions in the large airways that were obstructed, so fibrotic obstructing airway lesions. And on lung function tests, which I show here, she did have significant obstruction with some response to bronchodilator, but not complete, and also evidence of hyperinflation. So she had multiple stenotic airway lesions in addition to small airways disease due to endobronchial TB that was diagnosed in a very delayed fashion because of her status of pregnancy. So how does TB cause lung damage? I know in a couple of weeks, I believe we have a speaker on that, so I'm gonna keep it very short, but suffice to say, the difference between controlling a TB infection, here you can pick your bone complex here, calcified lymph node here in the right hilum and a small calcified granuloma in the periphery, and progression is the host immune reaction. So to keep it general, we have the neutrophilic inflammation with all these proteinases that can lead to acute tissue destruction. We do have the adaptive immune response, CD4 count. People with advanced HIV do not get this kind of post-primary TB manifestation. They more get the miliary pattern that leads to less tissue destruction. And then we've got the Greek alphabet here, TNF alpha, TGF beta, interferon gamma. And not to forget, we've got a microbiological component here. The bacterial load correlates with lung destruction, drug resistance, which means it takes a longer time for the infection to clear when you put them on treatment, delayed clearance. In our patient, we had a delayed diagnosis of this, so all these to progressive lung destruction. So, of the time we think about restrictive disease, right? You've got a destructive lobe and things like that. But how many people with radiographic post-TB changes have chronic airway obstruction? 5, 15, 25, or 50%. Who is for one? 5%. 15, 25, 50. All right, nice collection of answers. It's 25%. We know that from a nationwide, again, Korean study on COPD, where they checked chest X-ray spirometry. More than 1,000 subjects, 167 had TB sequelae on imaging with some sort of a scar, and 26% of those had airway obstruction compared to 8.6% without chest X-ray changes. Among the first data that TB has been associated with obstructive lung physiology came out of the Platino study, which was published in 2007. It was a large survey, more than 5,000 people in 5 metropolitan regions in South America, ranging from Mexico City down to Montevideo. They collected demographic data, health data, and spirometry. And when you looked at the self-reported question, do you have a history of active TB? The answer was yes. They found obstructive lung disease, 31% of cases, compared to only 14% if the answer was no. So double the risk of getting obstructive lung disease. We have more granular data from more recent studies done in South Africa. This is again from Stellenbosch, it's the same group that looked at the pediatric cases, was published 5 years ago. They looked at 43 patients with active TB at diagnosis and followed them from diagnosis to completion of treatment with serial PFTs and CTs. While they found all improvement of lung function parameters over 6 months into treatment, 15% developed significant airflow obstruction. And on the CAT scan, there was evidence of air trapping that was at times progressing beyond treatment completion. So these are the cumulative data. These are medians. I put a little yardstick here for your vital capacity. But what is actually interesting here between visit 2, 3 that was during the treatment and visit 5, which was upon treatment completion, I think it was a year after treatment completion, you see the residual volume kind of keeps creeping up. So there is progression of air trapping going on. They matched that with CAT scans. This is just one example of an individual who had widespread patchy consolidation here in the left upper lobe, for example. And upon treatment completion, you see that that area matches an area of air trapping, essentially. This is a report of one particular individual, a 23-year-old man, again from the same group, who had no history of smoking, who had completed treatment for TB, and upon completion had developed severe airflow obstruction, was highly symptomatic. So they got a CAT scan again. Here was in an expiratory images. They saw gas trapping that involved between 50 and 75% of his lung. And they got a VATS biopsy. And here they found fibrotic granuloma adjacent to small areas that have been severely narrowed. So this is a bronchiolitis picture, similar to what I had shown you initially. Again, looking at kids, think about where's your peak, your peak pulmonary function land, you know, as you continue with your life. This is again from South Africa. There are a lot of TB in South Africa. You know that. We looked at 50 adolescents of age around 15 with active TB and compared serum lung function measurements with 50 TB-exposed controls. In the beginning, 2 months into treatment, at completion of treatment, and only 30% had a normal lung function upon treatment completion. Majority had restriction, but 40% also had obstruction. These are the data. Look at air trapping, 12%, 5 individuals, 12% at 2 months. Some of them got better, 2 out of 5. But then some of the patients here, 3% started off with obstructive lung disease and you know, went up to 5, 14% ended up with obstruction at treatment completion. One concerning findings where the authors did point out is that the control group also had abnormal lung function findings, more than half of them, but this was mostly a restrictive pattern. So to summarize COPD and TB, there's a clear association with obstructive lung disease. I think we more and more appreciate that. Early detection of the disease, effective treatment is important. There's an association between multi-drug resistant TB and worsening lung function, which is most likely due to delayed clearance. So now we do have more effective treatment regimens, even for multi-drug resistant disease. There's a BPAL regimen that recently has been published and now has been highly recommended. So case finding, early treatment, effective treatment is important. Post-TB screening, you like to see these people. TB at the end is a lung disease, right? So we like to see spirometry. We should evaluate them for small areas disease if we don't see overt obstruction on these PFDs. Some people need evaluation for large airway disease, such as the patient I had shown you. And we should screen for secondary infection that can make obstructive airway disease and overall lung function worse. We see colonization with other bacteria, Pseudomonas, gram-negative spectrum, fungi, mycobacteria. There is data out of India that Aspergillus colonization has been associated with recurrent exacerbations, like asthma type exacerbations. And we do see chronic pulmonary aspergillosis also. They need good pulmonary care, smoking cessation, rehab, appropriate inhaler regimens, airway clearance, and vaccines to prevent further respiratory infections. So I talked a lot about RA, I talked a lot about TB and other infections. How about truly tobacco-associated COPD? This one. I think what I want to take away is that small airway disease is a cardinal feature in all the other forms of obstructive lung disease, but also in our typically tobacco-associated COPD. Early detection of small airway disease correlates with future lung function decline. The presence correlates with symptoms in people what we call pre-COPD, meaning they do have normal spirometry, but they have respiratory symptoms. There's no evidence that mucus plugging, which is an evidence of small airway dysfunction, correlates with lung function decline. And small airway disease may precede emphysema development. So that was a study where they took biological samples from people who underwent lobar resection, for others knowing their gold status or lung transplant, the explant at gold stage 4, and they looked at the quantitative, the lung injury, essentially, the airway disease. So they took this micro CT scans, and based on these 3D reconstructions, they took serial histological slides to quantify small airway disease and emphysema. And this is what they found. We look at the whole lung emphysema based on the CT, sure. If you have a gold stage 4, they found a lot of emphysema. They didn't find a lot of emphysema on the lower gold stages. And that was different when they looked at quantitative analysis of diseased airways. The number of total small airways and the number of diseased airways. Even with gold stage 1, they found a significant increase in the number of diseased small airways. So a decrease in overall small airways, which I didn't show you here, an increase in the number of diseased small airways. So coming back to that Lancet paper from 22 that wanted to alert the community about the global problem with COPD, and that we should do better, that we usually catch it late. So this is our current state. We see a lung function decline. Well, we don't see it. We presume there's a lung function decline, and we only start making the diagnosis once the patient does get symptomatic. At that point, it's lost a significant amount of the lung structure, mostly small airways function, and then, tries to catch up to mitigate symptoms. Is there a way to diagnose COPD much more early, to intervene early to prevent this loss of lung function? I think we're getting there, looking especially at small airways with imaging and other parameters in lung function testing. So this is what I had shown you in the study of adolescents with HIV. So HRCT can pick up on small airway disease. Surrogates are central lobar nodules, linear branching, meaning with bronchial pattern, mosaicism, bronchial obstruction, air trapping. Usually it's better to get in an expiratory imagist for that, but these are already, indicated that there could be something there just on your plain CT. More recently, people got more sophisticated with this parametric response mapping. What they do here, they essentially match individual regions, the voxels, on an in and expiratory CT, and they map how the density of that voxel changes within an expiration as a marker of normal lung, region with functional small airway disease, and emphysematous and full-blown emphysema. So that, I think, is promising to detect small airway disease early on before you see evidence of emphysema. There's an example of some patient with a COPD. We see here part of the lungs with emphysema, part of the lung with small airway disease, and that is compared to somebody who did not is a non-smoker of the same age group. I think it was a 50-year-old patient here. How about PFTs? There's been an recent interest in looking at a parameter called the FEV3 to 6 ratio, which takes into consideration essentially the angle of this plateau, right? The very end of our PFT. So FEV6 is closely correlating to our FVC, and then the FEV3, when you take that ratio, that's been associated with a small airway disease on quantitative imaging. As we've shown that this parameter does decrease time to first respiratory exacerbation and future development of COPD. They go with low limits of normal. I looked them up. For an age of 40, a low limit of normal of that ratio is 0.93, and at age 80 is 0.89. So something a sophisticated PFT software should be able to give us. So our take-home points. I hope I've convinced you that COPD is the result of a complex interplay between environment and host. Worldwide, half of the cases occur in non-smokers. Rheumatoid arthritis, as an example of a systemic disease that increases your risk of developing COPD, has a bidirectional relation. I think that's a very interesting biology here. Infections are associated with COPD and are a modifiable risk factor. And small airways do play a very cardinal role in early disease and progression. I think we do have the tools now to investigate, to assess small airways, and I hope that's going to open the door for early intervention to prevent development of advanced COPD in the future. Thank you very much. A shout out to our COPD group and our airway group at the Winchester. Thanks for your time.
Thanks, Sebastian, for your wonderful talk. Does anybody have questions, comments? Ed?
Thank you. Great talk. I had two questions. One was you mentioned about childhood infections and the risk of COPD. I didn't hear mention about neonatal, and there's some evidence about neonatal infections, bronchopulmonary dysplasia, but is it safe to assume that could also be one risk factor for developing COPD later in life?
Absolutely. Yeah, I didn't go into detail on that, but absolutely right. Same thing about, how it does impair the development of your peak lung function. So yes, there are data that bronchodysplasia is associated with obstructive airway disease.
And I did have one other question about your small airways disease having prognostic value, but have there been any studies or evidence to suggest that can you halt the small airway disease remodeling? Can you stop it is stopping smoking, stopping it? In other words, is it a therapeutic target or is this just an effect?
If you could repeat the question so the online folks can hear.
So yes, for Zoomland, it came through. All right, so the question, it's an interesting question. There's a lot of, interest in how you could modify that. One thing that is probably more practical, the new inhaler generation, like Trelegy and whatever they're called. Actually, what they did is they decreased the particle size of that. So with the novel generation of inhalers, it's thought that the drugs are actually delivered to the small airways, which may actually make it have a positive impact here. I wonder, there are thoughts about, with that relation between rheumatoid arthritis, COPD, could like specific targeting the autoimmunity in rheumatoid arthritis, like IL-6 blockers, could that have a positive impact on small airways disease? It's a hypothesis. I haven't seen any data. In terms of TB, I always wondered about how about inhaled antibiotics, inhaled steroids that also got to reach the small airways if you can actually help preventing progression of that part of the disease. So I'm not sure if there's going to be one answer to all that. I think the topic is fascinating, and I hope you're going to see some therapeutic effects, but so far it's mostly hypothesis.
So Sebastian, very provocative, and one of the things that I've noticed in just talks in general here about disease, that we sometimes take a disease and say, okay, we should break it up into different types because all lung cancer isn't the same, or all hypertension isn't the same. And I'm curious, when it comes to COPD, how you decide to include what comes under the COPD umbrella and what we exclude from it. So for example, I would think that rheumatoid arthritis and LIP and past infections might actually be a different kind of disease ultimately than smoking related to COPD. And maybe this was just for a matter of time, but we didn't talk about like chronic asthma with fixed obstruction today, or bronchiectasis with fixed obstruction, where we tend not to use that term COPD when we're talking about those patients. So getting back to this talk, is this all COPD, or is this just a collection of different diseases that you include under an umbrella of COPD?
So answer number one, we'd all like to see them in our COPD clinic. Number two, I think, you know, it was a little provocative, but like with my 3 histology slides, they all look the same, but for sure there are differences when you look at the overall gestalt of the picture. Nevertheless, COPD on its own has been shown to be a very heterogeneous group of disease, starting off with chronic bronchitis, blue bloater versus emphysema, pink puffer, and all that. So I think, especially since we see more and more if we look at it, we see more and more structural airway disease to start with, and then all these other factors that influence your risk of developing COPD. So I think the term itself, like, you know, opens up to a lot of variety. So when we see these patients in our clinic, we ask all these questions. We look at early childhood infections. We look at HIV status and things like that.
Can I just make a comment about that also? I think the final common pathway here is that the patient has relevant symptoms and they have airflow obstruction. And so I think one could logically conclude that they are having potentially differing risk factors that lead to an airflow obstructive picture. But I think one of the initial intents of the Stoltz Lancet Commission document was, by creating the different sort of buckets of potential categories of risk factors, to highlight how much we still don't know about the pathobiology and the underlying cellular and molecular mechanisms, and, you know, the different trajectories of COPD and the different risk factors. And I think the point of raising that is to now highlight that we need to study that, because we also don't know yet what particular differences in treatment may be needed or may be effective. And to that, I had a question for you about our post-TB COPD, Sebastian, and your comfort level with inhaled corticosteroids in that group, or discomfort level. And should we be treating them the same way as our other COPD people?
It's a good question. As we all know, we're a little bit concerned about using inhaled corticosteroids in like with a potential risk for infection. Having said that, you know, if you think about active TB treatment, once you know you are on an active regimen, there is no, the concern is low that you're gonna lose control of infection with using corticosteroids. We use them for CNS TB. We use them, and there's a debate how much it helps when you see these large area obstructions. People have been using them for GI TB, pericarditis, and things like that. So I think once your infection is actively controlled, using steroids is okay for the most. Now, you're probably coming at the post-TB folks, which we also think that they are prone to get all sorts of infection. And I think just think about, well, I may use steroids because of the bronchiolitis. I don't think we have the data to support that. When you look at the histology, which is scarce, but the ones we have, it looks like this process is already being fibrotic and calcified and so on. On the other hand, if you have somebody, for example, who has aspergillus colonization and sensitization, it develops an asthma type of phenotype, is with chronic exacerbations, I would use that. So I think when you look at the reviews, people say if you do have evidence of an reactive airway disease, acutely reactive airway asthma type of picture, you should use them. Otherwise, yes, we should be careful.
Great. Well, I think we've run out of time. And I just again like to thank Sebastian for his wonderful thought-provoking talk, and I'm sure he'd be willing to answer additional questions. Thanks again, Sebastian.
Thank you so much. Thank you.